Did you hear that commitment in his voice? There's a man that's committed. And I heard that in Dr. Box's voice too. These people are committed to bringing our state from the depths of wherever we are in terms of infant mortality and the opioids that are being used. They're committed to making things right, getting us started, getting the initiative started to help stamp out this terrible, terrible thing that's attacking our children, many adults. But you know what? I think we can do it. What do you think? What do you think? All right. Commitment is the word. Thanks, Jim. That was a fantastic presentation. Now, we're going to continue with the tweet and emails your questions are presented. So in case you didn't get the email address, let me give it to you one more time. It's hashtag, capital I, capital N, Labor of Love 17. Labor and love are capped. Okay? Next, I'd like to introduce Paul Jarris. He currently serves as the Chief Medical Officer and Senior Vice President of the March of Dimes, a past Commissioner of Health in Vermont, and Executive Director of the Association of State and Territorial Health Officials. He is a nationally recognized expert in healthcare policy, clinical initiatives, public health and disease prevention, and wellness. Before I bring him on, I want you to know that last night we had just a marvelous dinner here. It was just wonderful. I gotta say, the dessert was great. Jarvis not only had the chocolate cake, but he had the other dessert as well, so he's a sweet-toothed man. Let me introduce you to Dr. Paul Jarvis. Sweet-toothed man.
I deny it completely. So, anyway, it's a real pleasure to be here, and I'm glad you're all here today. It's a very, very important meeting, and I want to start this meeting with Casey and Izzy. It's an important reminder. We talk so much about statistics, about figures, about numbers, but every one of those is a real person, and it's for people like Izzy and her mom that were here. Also a wonderful example of how pulling a family together and offering that support for a chronic illness is so incredibly important. And both Dr. Box and Mr. McClellan gave amazing presentations. It's going to be fantastic to watch what Indiana does under their leadership. I don't think Mr. McClellan could have laid out a better public policy here. The comprehensiveness of it, the treatment, the talk of treatment, of recovery, of support, because that really is the direction we have to go in. For far too long, this country took a exclusively law enforcement approach, a war on drugs, and it didn't work. All it did was fill our prisons and break up our families. So I'm really encouraged to watch you here in Indiana and what you're doing. So why do we have an opioid epidemic? It's important to remember that NAS is part of a bigger epidemic, an important part. But that epidemic is complex, as Mr. McClellan said. There is no single factor, and we have to resist the temptation to look for that silver bullet. What's the one thing we need to do? There's absolutely no one thing we need to do. There's this expression in quality improvement, which came out of systems work, saying that every system is perfectly designed to get the results it gets. And our system in this country is perfectly designed to create an opioid epidemic, an NAS. It's not an accident. There's no one bad actor here. In fact, every one of us in the society is responsible for this situation, and every one of us needs to take a part of it. The research community. Are you aware of the research to support opioids for chronic pain? Well, if you are, please send it on. There isn't good research. There are a couple of studies, small numbers of people, and they study people on opioids for 3 months and then end the study. Well, how do we define chronic pain? Pain for 3 months. It's not been studied, and yet we give it all the time. There's a study in Denmark that actually looked out 6 months or more at people with chronic pain taking opioids, and they found no improvement in quality of life on multiple measures. So some people do respond. if they're carefully selected, maybe 30 to 50%. But it's not the panacea. And like we just heard, so many patients come in to our healthcare system and we produce drug addiction. We produce substance use disorder by the way we treat them. I'll give you an example. I broke my clavicle in a mountain bike race. It was a pretty bad break, 2 surgeries. Within 10 days of that accident, I had been given prescriptions for 210 oxys. If I had taken them as directed, I would have overdosed and died. The first fire department in the country that started using naloxone, I talked to the fire chief, and his firemen were very resistant to it. But the first person they saved was a middle-aged man who had had surgery that day, came home, took his meds as prescribed, and overdosed. It changed completely how the fire department looked at naloxone. The FDA looks at one product at a time. It does, and it looks at that product when used as medically prescribed. It does not take into account what happens when that product is used outside of its intended use, and it does not look at the public health implications. So that we just recently had an IOM committee and study and recommended the FDA has got to look at the public health implications and not just look at one drug at a time, because the last thing we need is another drug out there that does nothing different than any other drug, and there's no evidence that one of these pain medicines works better than another. I would say judiciary, law enforcement, criminal justice, anybody in the room here? We have got to work with them. I'll talk a little bit later about drug courts or treatment courts. The last thing we want to do is to take a young person and send them to prison. It's drug university. They need treatment. Now, violent crime perhaps is different, but most people in prisons are not violent criminals. We break up families. We split moms and babies. We make it into a multi-generational problem. I am interested, though, are there any of the criminal elements in the room? If you'd raise your hand high. So, they're very, very sophisticated. There was a bust 2 days ago in New York City, part of a Mexican cartel. They busted a middle-aged couple dressed like any other middle-aged couple in an apartment. They were up here as emissaries from the drug cartels. They had enough fentanyl with them to kill 30,000 people. That's more than a dirty bomb would kill. It's a weapon of mass destruction, and we have got, of course, to take it seriously in the criminal justice system also. But the pharmaceutical manufacturers, have you read the story of OxyContin in Purdue, where they basically started, I mean, they've been many lawsuits against them for over-marketing OxyContin, saying it's not addictive. It can be used for multiple things. Recently in Indiana, you had the Opana outbreak associated with HIV down in Clark County, and I went down there with with your new Surgeon General to view that community, and it was a failed community. People were taking that drug-resistant medication and injecting it up to 20 times a day. It was not drug-resistant, but it has marketed that way. So I'll keep going on here, but in healthcare, there's certainly no innocence there. People have heard of the 5th vital sign. That was an attempt, in addition to blood pressure, temperature, heart rate. People were supposed to be assessed on their pain as the 5th vital sign, every patient. And what happened then also is there's surveys done of hospitals, of doctors, which actually affect their payment. And I got this after a recent another mountain bike crash, visit. And the question from this Prescaney survey was, did the doctor do everything possible to control your pain? That puts a lot of pressure on doctors. And the idea is not to do everything possible. The idea is to help someone be functional. And ibuprofen worked just fine. So I won't keep going with this because it can take forever, but just a bit of awfulizing. You all know how serious this is, the rate of increase in death. We surpassed the peak gun deaths, the peak HIV deaths, peak car crashes. So now this is a major killer in this country. And I mean, look at that curve, pretty awful. So where did it begin? Well, of course, the human mind will always seek substances that produce a reward. But in this case, we really started to loosen up prescribing the opioid pain relievers. These are prescription drugs. And if you look down at the top dotted line, that's the sales. And look at the death, tracks right along with it. Fortunately, in this treatment tracks along, but at a much lower rate. We still do not have sufficient treatment. So this is the prescription drugs itself. We push this stuff onto the market, like the prescriptions I got, or like when you go get your wisdom teeth out, which have been shown it can be controlled with just ibuprofen, but you're going to get a prescription for narcotics probably. We push this stuff out there. Now, the point of this slide is to say there is one drug trade. There is not a separate drug trade for prescription drugs from heroin, fentanyl, and street drugs. It is one drug trade. Chemically, these things are very similar. Some are much more potent, like fentanyl, so they're much more deadly. But the brain really can't tell much of a difference. And so if you can't get your prescription drugs, or you need something stronger, you may turn to heroin. I had a farmer once up in Vermont, pinned up against the wall of his barn by a cow, could not get any relief from the medical system, and finally somebody said, try heroin. And guess what? His pain got better, and he became addicted. So what we're seeing now also is of the people using heroin and the synthetic opioids, because they're often mixed now, 80% of them began with prescription drugs. Prescription drugs are expensive. Heroin's very available, and now fentanyl, unfortunately, is very available. And so people move on. It's more available, it's cheaper, it's easier to get, unfortunately. So people will switch from prescription drugs into heroin. Now, that doesn't mean they necessarily stop seeking the prescription drugs, because if you sell 2 OxyContin a day, depending on the market you're in, you can make between $8,000 and $25,000 a year to help support other needs you have in other drugs. So they're very mixed, these two things. And so please remove from your mind that there's a difference in the drug trade. It's one drug trade, different suppliers. So that's why we're also seeing tremendous increases now, and you can see how it's past the prescribed drugs, of overdose for heroin and fentanyl. Now, fentanyl, you may know, is also used as a prescription in a patch for long-acting pain. To further the idea that there's one trade out there, the manufacturers who make the pill presses sell them to legitimate drug producers. They also sell them on the black market to cartels who press their own pills. So it's not always clear, if you look at a pill, did this come off the illegal market or did this come out of the medical market? And some of the same factories in China that produce fentanyl to sell into our prescription drug supply sell it outside of that to be used illegally. It's a very intertwined trade. We talk a lot about death, but death is the tip of the iceberg. This slide, again, is larger on healthcare, but for every one person who dies, 825 non-medical users of prescription drugs. And those people, it's harder to measure what happens there. Absence from work, on-the-job injuries, automobile accidents, depression, and many other social factors here. So we have to remember, this is not just a drug and the effect of a drug. It is a whole constellation of things around the use of these drugs. So, pregnancy. Women, of course, of childbearing age are in the system where opioids are used so heavily. And as we mentioned, many people start for the best of medical reasons on these things and then become habituated and go on to have a substance use disorder. But to me, it's very impressive that of women of childbearing age, a quarter of privately insured women and a third of Medicaid enrolled women have fill a prescription annually for opioids. Does that sound like a lot to you? It sure does to me, that 1 of every 3 women filling an opioid prescription in childbearing age. We really have to look at what we are doing, and is that the necessary treatment, or are there other alternatives that are non-opioid that could be used? And then this other study, looking at a private practice, for example, small numbers, but 6.5% rate of opioid use from urine samples in a private practice. That's a lot. That's a lot of opioid use. Think about, I think, what do you have, 84,000 deliveries a year here? How many women are we talking about? 6.5% of them are exposed to an opioid. Way too many. So the point is that when we look now at NAS, we have to get out of this mindset that these are criminals or these are bad people. Many people who enter this are using opioids because they've been prescribed by their provider. the data from Tennessee, I'll show you that in a minute. But there are people with chronic pain, whether they should or should not be getting opioids, are being prescribed by their doctors. There's people with psychiatric or neurological conditions being prescribed medicines by their doctors. There is people in substance use treatment programs which are using the methadone or the buprenorphine, which is prescribed and is what we want to have happen with women with substance use disorder during pregnancy. It takes them away from the much less safe injection or illegal drugs. Much safer also than trying to withdraw women in pregnancy, where the babies don't do as well. So many women exposed to narcotics are exposed in the healthcare system. There are others who also are using, most commonly, medications from friends or family or others. And yes, there are others who are using heroin, street drugs, but it's a whole mixed bag. Typically, when we look at NAS, we don't differentiate in our coding and things like that about how many of these women are using a legitimately prescribed medicine from how many are not. But the fact of the matter is they will all respond to treatment. This is from Tennessee, and I won't talk much about it because Michael Warren's going to be talking later, but if you look down on the bottom right side of this, and I'm sorry, I hope you can read it, but down here, you'll see the percentage of women and where they got their drugs. It adds up to more than 100% because some people have more than one source. The number one source, 55%, is supervised replacement therapy. That's what we want to have happening with women's substance use disorder. And number two, supervised pain therapy under the care of a doctor. Number three, therapy for psychiatric neurologic conditions. That's 80% of the women. None of those should be a surprise if their children have NAS. Every one of them should be anticipated, and we should be ready for that baby when it's born. There should be no surprises. But I bet for the neonatologists and the nurses in the room here, that's not the case. We are not picking this up in the healthcare system. Tennessee, again, it's not just about death, but what happens to these children. TennCare, one of their best practices is that neonatal abstinence syndrome is a reportable condition. So every one of those babies gets reported to the Department of Health with other factors among it, so they actually have some data to know what to do. And I remember hearing, you don't have that kind of data in Indiana, so it's really hard to know what's going on. Making a reportable condition makes a lot of sense. So here, the costs are quite different. But look at the Child Protective Services. In other TennCare kids, in general, 1.4% of births go into Child Protective Services. Of NAS infants, 22.7%. And we did hear from Mr. McClellan also the number of kids going into Child Protective Services here. The goal is to keep the mom and baby together. It can be done, not to send mom to prison and baby to Child Protective Services. We're splitting a family back apart. Mom and baby will both do more poorly there. This is just something I picked out of your paper in Indianapolis showing about the burden on the foster care system. The more important burden there, though, is the burden on the mom and baby if they're not treated appropriately. So neonatal abstinence syndrome, clinically, you can look at this here. Interestingly enough, there's not a lot of great data yet on the long-term effects on the baby. We still have to do a lot more to determine what it does cognitively, developmentally through the school years, and we don't have great data on that yet. So what do we need to do? One of the most important things is avoidance of unintended pregnancy. 45% of the pregnancies in this country are unintended. So if a mom is receiving treatment from their provider with an opioid, they should have counseling, they should have informed consent, and there should be consideration of co-prescribing of a contraceptive so that they can choose when to become pregnant when they are healthy enough to become pregnant. This is often not thought of as part of the strategy here, but it is critically important. Avoidance of opioids in childbearing age, we saw that 1/4, 1/3. Co-prescribing contraception, that's not the standard practice, but I really think it's something you should look at as a state, that true informed consent and consideration of co-prescribing. Prescription drug monitoring programs, it may be different in every state, but in many states, the OBs aren't accessing the prescription drug monitoring program for new pregnant women in their practice. and I still haven't seen many systems where labor and delivery checks it, for example. Or maybe even the neonatologist checks the mom's prescription drug monitoring system to see, did that mom have opioids on board? We have to become much more rigorous about this. ACOG does recommend universal screening. It's not being done rigorously, from what I can tell, and I'd love to learn that's different in Indiana. Every woman needs to be assessed, because you can't tell who is using and who is not using, who is prescribed and who is not. And then the communication between pediatric and neonatal, between obstetrics and pediatrics is very problematic in some settings. I heard some good news last night about Indiana, but there are systems in which the pediatrician can't access the mom's record. And in other systems, neither the obstetrician or pediatrician can access the mom's record if she's under treatment for substance use. So those barriers we need to break down. Very importantly, we need a safe harbor. We need to create an environment where every mother can safely come forward and say, I'm using an opioid. Either it's prescribed by so-and-so, or I'm using an opioid that my grandmom was prescribed. We heard a story earlier where that was too uncomfortable to happen. It would have been a whole lot better to begin treatment early. And Kentucky and certain states have criminalized this, and basically criminalized the mom using opioids, where she then can be charged, her kid goes in child protective services. That is a huge mistake. That will kill babies, and that will separate families for generations. So we need to treat this as a disease. So good, be vigilant about that, because sometimes they sneak through. The referral pattern, is there an easy way for an obstetrician or a family doc to refer? When you're seeing 40 patients a day, sometimes the question isn't asked because you don't have time to figure out. If the woman says, yes, I'm using, that's the last thing you want to know. We have to wrap around those providers. So one easy phone call, and someone takes it over, does the assessment for the mom, gets her into treatment, brings in the social services, and helps her. We can't expect doctors seeing 30 or 40 patients a day to do that. It's just not going to happen. We need to have access to treatment. And as you heard, you're expanding your treatment facilities. Pregnant women should go to the front of the line. We simply do not have enough treatment in this country. I tried to work where I came from in Vermont with the corrections department to treat the women in corrections. And the commissioner of corrections was, in fact, a social worker by background. He said to me, the reason I can't offer treatment in corrections, in prison, is because there isn't treatment in the community. And people would simply get arrested to come here to get treatment. He's right. People, when they need treatment, and they'll do almost anything to get it. So we have to have the treatment outside of the prison system, and we need it in the prison system. The wraparound services are so important. This is, again, not just a matter of a medication or a drug. There's a whole social constellation around here we have to help people with. We have to get them into a supportive recovery environment. We have to look at their housing. We have to look at their transportation. We have to look at vocational training. We need to make sure they're supported in recovery. If you treat someone, send them back to the same old environment, there's nothing more threatening to their social network of users than to have somebody come back who does not want to use. And so there's tons of pressure on them. We need to wrap around and keep them together. Again, I would say the objective here is to keep the mother-baby dyad together and healthy. Treatment courts, I believe you do have treatment courts here, very important. And working with your judiciary on this, with healthcare, with social services, is incredibly important. Really what we want to do is have people come forward if they're nonviolent offenders, but they have committed a crime, go before a specialized judge, and there's a whole society of these judges, and have the judge, if you will, sentence them to treatment and follow up. And if they complete their treatment, if they're in treatment, they don't go to prison. If they do continue to commit a crime, don't go into treatment, then perhaps corrections is the right place for them. But it is a very effective way, because we are filling up our prisons and breaking and destroying families. So a couple of things out there. North Carolina, I mean, there's a lot of good stuff out there, but North Carolina has a very good program educating providers and healthcare folks who are taking care of women of reproductive age about opioids, educating them about women who are on opioids of reproductive age, prescribed or not, and some different screening tools, and how to work with families and patients who are exposed. Because unfortunately, in this country, opioids are almost inevitable, it seems, which is such a shame. So it's important to know how to do this in your busy practice setting, with your nursing, with your social services. The standardization of care is incredibly important also. There is so much variation in how babies are treated, in this case with NAS, and how the moms are treated in hospitals. We know that care improves if you have algorithms and clinical guidelines and approach it from a systematic way. That tends not to be how we do it in medicine. We were all raised as cowboys and cowgirls, where of course we knew the best and we weren't going to follow anybody else's orders. That doesn't work anymore. So I would really encourage you to look at this Vermont-Oxford network. They bring in the protocols, they bring in how to organize your hospital, but most importantly, they bring in experts in quality improvement and systems improvement, so they can create a situation in your hospital or treatment center where the default is the right care. It's not about it being heroic delivering the right care, it's the default. Healthcare doesn't operate that way. And we need to adopt these from other industries, these notions of system development, quality improvement, and safety. I personally believe that any time a baby is born with NAS, it's an adverse event, and there should be a corrective action, a root cause analysis, corrective action plan. How did this happen? Particularly any baby born with NAS that was not anticipated. Why was this not picked up early on in the obstetrical care? There should be an investigation in that to improve the system. We tend not to do that. We tend to think these things are inevitable in healthcare, rather than saying, no, we're going to actually figure out how to prevent this from ever happening again. Washington State has an excellent program, and I encourage you to take a look at that. This state has developed an incredible program where, again, a mom can identify, they wrap around her with treatment, they wrap around her with social services, support, they follow her through the pregnancy, and they'll follow her 3 years after, the mom-baby dyad. It's a supportive environment. It is to help them in recovery. They have a chronic illness. That's a whole different approach, and we did hear Mr. McClellan talk about this type of approach. A whole different approach than a punitive approach of, this is a bad mom doing bad things with a moral illness. That's just old thinking. This is a brain disease. I'll also say that, with other chronic illnesses like, for example, congestive heart failure, people relapse. They come back into the ER with fluid on their lungs. Do we ever kick them out and say, you dirtball, you ate a ham sandwich, get out of my ER? We don't. And yet that's how we treat. We recognize that's a chronic illness, that people occasionally will have that ham sandwich or whatever it happens to be and have a relapse. We need to understand this is a long-term disease. Treatment works, recovery works, and we've got to recognize that. A few things with the March of Dimes. One of the things particularly that I think is interesting, a lot of educational, if you need plain English education, English and Spanish, I'd encourage you to take a look at it. We have nursing, professional nursing education. We are working on a project with the CDC in 3 different states where we are having the birth defects registry track neonatal absence, babies born with neonatal absence syndrome in the long run, because we're trying to figure out what is the natural history for these babies, what actually happens over time. And really, we don't have longitudinal studies now to know, what is their school performance like? Are they in the long run more likely themselves to have a problem with opioids? So there's so much we need to learn here. And of course, we're working a lot on advocacy here, and policy and the legislatures are incredibly important. So I want to go back to this idea. It's a system. There's no silver bullet. We have to look at a whole part of this and everything that contributes to it, and recognize that NAS and pregnant women are one part of a much larger system. Stigma is harmful. Recognizing this is a brain disease, and we don't have time, and maybe someone else go through the neurochemicals involved in this, but it is a brain disease. We need to treat it that way. Many people enter into substance use disorder with the best of intentions under medical treatment, and we cause the problem. So to abandon them and say somehow it's their fault is absolutely the wrong way to do this. And the last thing I'll say again is, remember, this is all about healthy moms and babies, healthy families, and that means treatment, and support and keeping the mom and baby together. That really is our goal here. So with that, we'll say thank you. And Dr. Lou's coming up. He'll be fantastic.